And so now on our global journey, we're going to travel from Switzerland to Ireland for our next presenter. Dr. Darushka Naidu is one of those people who just makes you feel smarter by being in her presence. If you were doing a group project in school, you know that she's going to be the one who's always doing the work, is going to make the team succeed. I had the honor of doing a panel with her at last year's ESMO in Madrid, and she just made all of us look good. So she's incredibly talented, another brilliant lung cancer leader at the top of her craft. Her area of expertise is immunotherapy and immune-related toxicities. We're at, as you heard some alluding to in Dr. Peters' talk, we're at an inflection point in the lung cancer field where we're starting to see this movement of treatments that are typically used for late-stage disease, targeted therapy, immunotherapy. We're starting to see that move into the early-stage space. And we know that if we can detect lung cancer as soon as possible, earlier, if we can intervene sooner, then we're going to have greater outcomes and greater success. And so there's a lot happening in this space right now in early-stage lung cancer. There's a lot of talk about whether you should treat a tumor before surgery, after surgery. There are certain complicated words, but Dr. Naidu is going to help us get educated and tell us about the latest advances that are happening in the management of early stage lung cancer. So welcome, Dr. Naidu.
Me?
Yes.
Okay. Hi, Amy. Thanks so much for this excellent introduction. I think Amy just described me as a nerd, but I'm really happy to have the description and, really pleased to be able to discuss this very important topic in an area of progress in lung cancer. So moving to the next slide, I think what's important to place into context is that, unfortunately, lung cancer is not created similarly to other diseases, in the sense that the vast majority of patients, unfortunately, present with advanced disease. Stage 3, stage 4 disease happens in about 80% of patients, and only a minority of patients have what we call earlier stage disease, in which treatment is delivered with curative intent. Hopefully, lung cancer screening and some other advancements might change this paradigm, but currently this is what we are dealing with. Sorry, moving forward. So our current approach in lung cancer, particularly for patients who do not have mutations, we take a patient with a newly diagnosed lung cancer, we do staging investigations, and then we do a biopsy of the tumor. And that biopsy, as mentioned before by Dr. Peters, we do a series of tests called biomarker studies. And that helps us to select the appropriate treatment for a patient. The very first step is to identify the stage of disease, meaning where in the body has the cancer moved to. And if this is a stage 1 or 2 cancer, generally we call it an early stage lung cancer. Some portion of stage 3s might be amenable to surgery and therefore are treated along that paradigm. Patients with stage 3 are called locally advanced lung cancers, and those in which disease may have moved beyond the lung are called advanced disease. And then we use some of these markers to pick the appropriate treatment, as you see here. So focusing specifically on early stage lung cancer, as I said before, 20 to 25% of patients have early stage lung cancer. And in most cases, we want to treat those patients definitively with surgery. Some data now suggesting that other forms of high dose radiation may be used instead, but in most cases, we try to do surgery. Despite this, 50% of patients with lung cancer will recur within the first 5 years. So this has told us for many years that surgery is likely not enough. But our treatment armamentarium for these patients has been limited, and really limited to chemotherapy for many years. So for many years we did surgery, and then after that we did chemotherapy for 3 months. And this provided some small amount of a 5-year survival benefit. You can see a 5% benefit, really a very small incremental gain in the survival curve that you see there. Another approach was to try to do chemotherapy before surgery. And this is sometimes called a neoadjuvant. So neo meaning new, the new or the first treatment that you give. And we see here that essentially the benefit is comparable. And there was a bit of debate then as to when was the optimum timing of giving treatment. And in this trial called the NATCH study, it showed that they were sort of identical in the area of chemotherapy. So platinum-based chemo was an accepted standard of care for maybe about 20 years. However, the landscape of early-stage lung cancer is changing. Now, based on the way we approach advanced disease, these are coming forward to how we approach early-stage disease. So we do biomarker testing for these patients to try to identify, is there an oncogenic driver mutation that might allow me to pick a targeted therapy, a tablet treatment that takes me down a different road and really is telling me more about the biology of the cancer. So we'll talk about the trials that underscore that approach. In patients in which there is no obvious driver mutation, or it is a mutation that may still respond to immunotherapy, then there is this evolving space, which we're going to talk about today, of giving either surgery with chemotherapy or immunotherapy on the back end, or flipping the paradigm and giving upfront treatment with chemo and immunotherapy followed by surgery, and then now some sandwich approaches where we give upfront chemoimmunotherapy and immunotherapy on the back end. So very much an evolving space. So specifically, when we think about lung cancer, early stage lung cancer, the first question we ask ourselves is surgery possible? And is surgery possible when a patient is initially presenting to us in the clinic? Because we don't have a crystal ball. We can't know in time if surgery is going to be the right thing or not. We only have the information that we have today. So based on today's information, we stage that disease. If it's stage 1B or stage 2, we consider it resectable. And then if it's stage 3 disease, stage 3 is complicated and comes in various different flavors. And so this really can be separated into resectable stage 3 or unresectable stage 3. And this is where the field is currently changing, as there is a blurring of the lines about what is deemed surgically resectable and what isn't in this new era of giving treatment up front. And we'll talk about that a little bit. So in general, this is our staging classification called the TNM stage. Stage 1 and 2 is broadly classified as early stage disease. And then some stage 3s may still be amenable to surgical resection and can be called loco-regional. So surgery, the standard ways to do surgery, there are different surgical approaches. Essentially, the surgical approach that's used is we try to do as minimally invasive a surgery as possible, and the goal is to try to take out the tumor with an adequate margin, meaning no evidence of any cancer cells at the outer edges of the surgical resection, and to take a certain number of lymph nodes, which are the areas in the middle of the chest in which the lung cancer commonly spreads to. And incomplete resection sometimes happens. This means when a surgery does not get an exact clean margin, and this can be due to technical difficulties or the nature of the cancer itself. And when this is microscopic, it's called R1. And when it's macroscopic, meaning you can see the tumor with a naked eye, then it is called R2. And this usually implies that we may have to do something more. So the treatment paradigm after surgery is constantly evolving in recent years. So as I mentioned, for the last 20 years, we did chemotherapy. It offered a very small but real benefit in terms of survival. Now we have seen the growth of using immunotherapy after surgery. So this is called adjuvant immunotherapy. And this is based on 2 studies, the Empower 10 study and the Pearl study, which were presented and published over the last number of years. Professor Peters leading the Pearl study, Empower 10 led by Heather Wakely and colleagues. And then I'll get to the Pacific trial. Actually, at this year's ESMO, just a few days ago, a third large phase 3 study from the Canadian group called BR31 was presented and had sort of similar results to Pearl's. And then for a separate group of patients, those patients who have a driver mutation who may not respond to immunotherapy, they could get a targeted therapy, a tablet treatment for a certain period of time after their surgery. And this is an example of one of the trials that has underscored that treatment decision called ADORA. So let's walk through these various approaches and what are the data that supports that. So for chemotherapy, the use of chemotherapy has been based on a large meta-analysis. A meta-analysis is a type of study in which the results of several clinical trials are pooled. And in this study, it showed that overall, the benefit for giving 3 months of chemotherapy is about 5% at 5 years. But the difficulty with giving chemotherapy after surgery is that in reality, only 57% of patients end up completing their planned chemotherapy for very understandable reasons. Surgery is very difficult on the body. It takes a while for a patient off. We're not treatment. So in comes immunotherapy. So Empower-10 was the very first adjuvant study in which immunotherapy was attempted for a year after chemotherapy. This study had the endpoint of disease-free survival, and it demonstrated, or it was studied in patients based on stage and patients whose tumors expressed this marker PD-L1, which tells us that the tumor may be more likely to respond to immunotherapy. We see that about 1,000 patients were enrolled to this study, and that the majority of patients had stage 2 and stage 3 disease. And broadly, what the study showed was what we call a separation of the curves, that giving immunotherapy in patients with stage 2 to 3A lung cancer, whose PD-L1 score was greater than 1%, this group had the greatest benefit, with a disease-free survival hazard ratio of 0.66, which means a reduction in the and this was a statistically significant finding. We see here the results in terms of toxicity. So overall, we see that this was largely a well-tolerated treatment, only about 10% of patients getting a severe side effect, and some of these patients developing an immune-related side effect, which was related to how the drug works in the body and is related to inflammation. And we see here around 8% of patients developing a severe immune-related toxicity. The second clinical trial that was undertaken and then subsequently published in The Lancet in 2022 evaluated the same question, but maybe with some slight differences in the study design. In this study, again, patients with early stage 1B to 3A resectable, so that local regional resectable group could enroll. This study assessed patients by all PD-L1 expression and allowed patients to receive chemo or not, whereas in the previous study, everybody had to have chemotherapy. And in this study, patients were then randomized 1-to-1 to a different immunotherapy medicine called pembrolizumab. The study had the same endpoint of disease-free survival. We see here that there was a disease-free survival benefit for pembrolizumab in all patients enrolled to the study, but maybe some counterintuitive results that those patients that had a high PD-L1 score weren't necessarily the ones that benefited. So this was classically, very difficult to interpret, but meant that we could give immunotherapy after surgery regardless of the PD-L1 score. And a very similar result seen in the Canadian study that was presented at ESMO just in the last few days. So switching gears for patients who have a different kind of lung cancer, those who have EGFR mutant lung cancer. So this is the type of lung cancer that classically doesn't respond to immunotherapy, is associated with those folks generally that are never smokers. They might have an EGFR mutation and go down a very different road after surgery. So in this trial called the ADAURA study, this was a big splash in the oncology world in the last number of years, resulting in not one, but 2 New England Journal papers. The first showing that if we give osimertinib, which is a tablet treatment, for 3 years after surgery, it dramatically reduces the risk of the cancer coming back with a hazard ratio of 0.21, so an 79 to 80% reduction in the risk of the disease coming back. And then we saw a similar benefit in terms of overall survival. And getting an overall survival benefit in this population has been elusive, but was subsequently seen. So really a game changer for these patients. And then now more recently, just in the last year, a very similar study was done for another group of patients that have biomarker-driven or oncogene-addicted lung cancers. So this is a slightly rarer subgroup, patients with ALK-rearranged lung cancer, which accounts for about 2 to 4% of patients with lung adenocarcinoma. Again, somewhat similar study design, early stage lung cancer that is a stage 1B to a 3A that has had surgery and found to have this ALK rearrangement. This design was a little bit different to the previous study. In the previous study, in this study, patients were assigned to getting alectinib or chemotherapy. In the previous study, there was the option for chemotherapy, and it was osimertinib or observation. So completely different design. So not all patients needed to have chemotherapy here. And what we see here is, again, an overwhelming benefit in terms of reducing the risk of the cancer returning, with a disease-free survival benefit, hazard ratio of 0.24. So a 76% reduction in the risk of recurrence from giving alectinib. On the right-hand side, you see something called a forest plot. As we explained to the fellows, we want to see the forest from the trees. So there's all the forests are all the different trees are the different subgroups of patients enrolled onto the study. And essentially what you see here is that all the subgroups favor using the treatment for alectinib. So regardless of age, sex, the fitness of the patient going in, whether they smoked or not, or their stage of disease, all of those patients appear to benefit from treatment with alectinib. Another question, sorry, the title here doesn't seem to have projected, is which patients benefit from some radiation after surgery? So this has been hotly debated over the last number of years, and a clinical trial called LUNGart was undertaken by Cécile Lepichou and colleagues, our colleagues in France. And in this study, patients who had a surgery for lung cancer but had persistent disease in the middle of the chest were randomly assigned to getting observation versus radiation. And effectively what this showed is that there was very little difference between the groups. And while the postoperative radiation may reduce the risk of the cancer returning in that area, it actually was associated with an increased risk of deaths. So many of our multidisciplinary teams have now moved away from giving postoperative radiation after surgery. So switching gears to the area of real change and progress in early stage lung cancer is this neoadjuvant paradigm. So flipping how we treat early stage lung cancer by, instead of doing surgery first, doing an all-over systemic treatment first, followed by surgery. So this was not new even in the chemotherapy era, and this is certainly something that is done routinely in breast cancer and in other cancers. So this was trialed in lung cancer in the phase 3 NATCH study, in which patients could receive chemotherapy upfront versus surgery. And what we see here from these survival curves is that the survival is identical in the case of chemo if you did surgery either upfront or after chemotherapy. However, what they did notice in the NATCH trial was that more patients were able to complete their planned treatment and more patients got to surgery as a result of giving treatment upfront. And really, these features, I think, have been critical pieces of information that have meant giving a more effective therapy like immunotherapy or the combination of both chemo and immunotherapy has shifted the dial, showing us that now giving an upfront treatment when that treatment happens to be more effective may actually improve outcomes for patients. And these are two of the seminal studies that have now been presented and published. The very first one is called Checkmate 816, and I'll take a deep dive into that. And here you see a clear separation of the curves with giving upfront treatment when you add immunotherapy, and the control arm there is chemotherapy alone. And this was recapitulated in the Keynote 671 trial, in which chemoimmunotherapy was given upfront with 1 year of immunotherapy on the back end. And many of these studies use an early outcome measure called pathologic complete response, meaning the proportion of patients who had their tumors completely disappear as a result of the treatment. And this is what we call an early or surrogate endpoint, often for good outcomes long-term, that is used in the breast cancer literature. Its use in the lung cancer literature does need further study, but is very reassuring. And then in terms of the neoadjuvant phase, giving an upfront treatment before surgery, could we do this in biomarker-enriched populations as well? Patients with EGFR mutant lung cancer and others. So here, again, some very important examples of how not all lung cancer is created equal. We see here the overwhelming benefits we see with chemo and immunotherapy before surgery for those types of lung cancers doesn't necessarily translate into oncogene-addicted lung cancers. When we give upfront targeted therapy chemotherapy, we might see some impressive shrinkages, but we do not see complete disappearance of the tumor. So really, the benefit of this approach in this type of lung cancer, I think, requires more data and may not be the same. So in terms of neoadjuvant chemoimmunotherapy, this is very much the new kid on the block in early stage lung cancer. And over the last couple of years, this is the sort of overall design of many of the studies. Patients have early stage lung cancer, stage 1B to 3. Now most of them are stage 2 to 3. We are shifting the goalposts with stage 3. Now we're including sometimes patients who may not have been deemed surgically operable, but in certain countries may be operable. And they are randomly assigned to getting 3 to 4 cycles of chemo and immunotherapy together, compared with chemotherapy alone. Patients then go to surgical resection, and then after that, they usually get a year of maintenance immunotherapy. These are the phase 3 trials that many have been presented and even published. You heard about Checkmate 816. The others that have been subsequently presented include Aegean, which uses the immunotherapy drug durvalumab, NeoTorch, which uses the immunotherapy drug toripalimab, Checkmate 77T, which like 816 uses the drug nivolumab, but then adds on the back-end treatment, the adjuvant portion, Keynote 671, the drug called pembrolizumab, and Empower 30, which we haven't seen yet, with the drug atezolizumab. So walking through this data one by one, the very first study that was that explored this approach in the phase 3 setting is Checkmate 816, and this was led by my colleague Patrick Ford at Johns Hopkins. So in this study, it was a small but important phase 3 study, just 358 patients. Patients had stage 1B to 3A lung cancer and were randomly assigned getting 2 doses of nivolumab immunotherapy with chemotherapy every 3 weeks compared to chemotherapy alone. Patients then had a CT scan, restaging, and then had surgery within 6 weeks of treatment. And then they had the option to receive further chemotherapy and radiation at the discretion of their treating provider. The primary endpoint of the study was pathologic complete response, meaning complete disappearance of the tumor. And the co-primary endpoint was event-free survival, meaning reducing the risk of the cancer returning or death. And what we saw here was that the study met both of its primary endpoints. So we saw that in a whopping 24% of patients, they had complete disappearance of their tumor just by adding the immunotherapy to the existing chemo. And this was compared with chemotherapy, where the rate of disappearance was only 2%. So adding this additional drug really changed what was happening in the tumor at a local level. And this translated into survival benefits for patients. We see here that at 2 years, 64% of patients, their cancer had not recurred and they had not passed away, compared to 45% of patients who had just received chemotherapy. And this was a statistically significant finding. What was also really interesting, and maybe we didn't expect as much, is that adding a third drug to the chemotherapy really didn't change the calculus in terms of toxicity. So we see here that around 94 and 98% of patients got toxicities, whether they got the addition of immunotherapy or not. And actually, in a way, adding immunotherapy was a bit safer. Only about 36% of patients had treatment-related toxicities that were severe, compared to 38% of patients who received chemotherapy alone. So overall, we would consider this really quite a safe treatment and no concerning toxicity signals. What was also interesting about this study is that it appeared that when we give immunotherapy early, we might be changing the biology or the natural history of lung cancer. So we know that for the majority of patients, when their cancer recurs, it is going to recur distantly. It is common for when lung cancer comes back, for it to come back in places like diffusely in the lungs, the liver, the brain, and the bones, as well as the adrenal glands. It is much less common to get lung cancer coming back inside the lung on its own. And what we saw again here is a change in the paradigm. We saw that with the addition of immunotherapy, which is seen in green, compared to chemotherapy, which is seen in gray, that a vast minority of patients had recurrent disease in the brain, only 4% of patients, as opposed to those who got chemotherapy alone, which was 13%. However, the rate of recurrence in the chest was similar, whether the patient got immunotherapy or chemotherapy. And really, this leads us to the question about whether additional local therapies like radiation may be important for us to assess in the future and what their role is going to be. Broadly, this study was a slam dunk across all different stages and all different PD-L1 scores. So what we see here is that the patients whose tumors were a little bit more advanced, the stage 3 population, and the patients whose tumors highly expressed the PD-L1 scores, so greater than 50%, they appeared to derive the most benefit. However, patients benefited regardless of their PD-L1 score. So we see here benefit in the 1 to 49 population and benefit in the less than 1% population, but a slightly more modest benefit. And we do see that the confidence interval crosses 1. So there's a little bit more of a question here. So this has underscored some differences in the regulatory approvals of these drugs based on the PD-L1 score. We also see that patients may benefit even regardless of stage, with some patients with stage 2 responding, less data on patients with stage 1B. Shifting gears to the other big study that really has changed what we do for early stage lung cancer is Keynote 671. So this study was presented at ASCO 2 years ago, then again updated at ESMO last year, and I was very privileged to be the discussant on what I think really was a practice-changing finding. The first phase 3 trial in early stage lung cancer to show an overall survival benefit. So really our gold standard outcome for patients with lung cancer. So the study schema is on your left there. Essentially, we see it's patients with earlier stage lung cancer, and they were randomly assigned to getting chemotherapy or chemotherapy with a different immunotherapy drug called pembrolizumab. Patients then had surgery, and then afterwards, on the investigational arm, received a year of immunotherapy with pembro compared to observation. And what we see here is there was a statistically significant improvement in overall survival with a hazard ratio of 0.72. And interestingly, we see that those curves continue to separate, which gives us hopefully an inkling of hope that this benefit may continue over time. And this has underscored an FDA approval in the early parts of this year. I think there's some really salient points to take in from the details of the study. And one of those points is, how much of the treatment patients get through at any one time. So if we look at the neoadjuvant portion, we see that around 87% of patients are able to complete 3 cycles of chemoimmunotherapy. But then when you get to the fourth, only 74% of patients are completing that treatment. So really, with each subsequent cycle, we are seeing that patients may find it difficult to get through those portions. So optimizing the right amount of doses, I think, is still a question. And then we see quite a rapid fall off in the after surgery portion. So after surgery, we see that about 70% of patients get 1 dose of treatment, but then only 40% of them are able to complete the full treatment. So really the optimum number of doses, how much benefit is being added from that portion of the treatment paradigm, these are all important questions that subsequent studies in the field are trying to answer. Some very important information from this that has also been seen in Checkmate 816 and other trials is trying to evaluate whether this disappearance of the tumor at the time of the surgical resection can give us a clue about what the journey for the patient is going to be like. And in this survival curve, what we see is on the very top, the dark sort of teal line and the solid purple line. These are patients who achieved complete disappearance of their tumor, pathologic complete response. And clearly, the patients who achieved that and were treated with immunotherapy do the best. The patients who achieved a complete response but even weren't treated with immunotherapy, they still do better, but this is a step ladder rather than a curve. So that's telling us that it's not that many patients in whom this situation happens. And then the other 2 curves are sort of sitting together. So the patients who don't have complete disappearance of their cancer, whether they got immunotherapy or not, appear to do much worse. However, the patients without a complete response who got immunotherapy do seem to do incrementally better than those who are simply observed. So this is the question that we are now dealing with in the field, is who needs the post-operative treatment, how much, with what agent, and is this pathologic complete response the right endpoint that's going to help us to sift through these various groups. So moving on to another study, this is very similar in the early stage disease setting. This is Aegean. It is essentially the same study, but done with the the treatment of durvalumab, which is an anti-PD-L1 agent, as opposed to pembro, an anti-PD-1 agent. This is now an approved option for patients with early-stage lung cancer. Very similar results, benefit in event-free survival, with 63% of patients who got the immunotherapy being event-free at 2 years, compared to just 52% of patients who got chemotherapy. And taking all of these sorts of learnings together, there are some very important points that I think a patient needs to understand as we move to this new paradigm. So I suppose the first question is this new approach where we give chemo and immunotherapy upfront if you don't have an oncogenic driver mutation, is that going to suit all patients? So it appears the answer is no. There is a proportion of patients who unfortunately don't make it to surgery for whatever reason. Either they become too unwell early, they're not a surgical candidate, or for some reason they are unable to complete their planned upfront treatment and do not get to surgery. And overall in Checkmate 816, this was about 17% of patients. So, nearly 1 in 5 patients. So what do we do for that group, and why does this not work for them? I think we need to understand that a little bit better and develop studies dedicated for them. Should we change our treatment based on the stage and the PD-L1 score? I think lots of differences of opinion in this area. Certainly if you were one was adopting a pick the winner approach, you would really pick the high PD-L1 expressors in the stage 3s, but still some benefit in those who have a more modest PD-L1 expression and in stage 2. So some differences in practice patterns related to this. And then, of course, as I mentioned before, is pathologic complete response a relevant endpoint? Meaning if somebody achieves a complete disappearance of their tumor after upfront chemoimmunotherapy, is this enough for us? Do we feel comfortable that we can stop the treatment and know that we are doing the best for our patients? So I think this has yet to be validated as to what we call a surrogate endpoint, meaning that pathologic complete response can truly predict someone is going to survive for longer. But there are studies validating this endpoint, and we anxiously await those results. So really, currently, it's a balancing act between an adjuvant or a neoadjuvant approach. The neoadjuvant approach on the right-hand side has the benefits of better treatment compliance, the opportunity to add treatment afterwards, gives you a sense of if the treatment is working from how well it works at the time of surgery, and may have the opportunity to shrink the tumor and potentially help with the success of surgery. The benefit of doing immunotherapy after surgery is that this is more common practice. It doesn't involve much of a change to our practice. There is no delay to the definitive treatment, which is surgery, no increased risk of post or preoperative complications, and we have all the information before we start treatment because we have removed all the tumor. So really, this balancing act is what is discussed with patients and care teams routinely now in our clinics, and is a different calculus for every patient. Moving on to the area I had mentioned before, should we think about giving targeted therapy in this kind of manner? So there have been 2 phase 2 trials looking at giving targeted therapies, earlier generation treatments such as erlotinib and afatinib in this area. And what we see is there does appear to be some incremental benefit in response. But no complete disappearances of tumor, with pathologic CR rates of around 3%. So not really the impressive benefit that we're seeing with chemoimmunotherapy. One of the bigger trials that have been done in the space, a trial using a more modern EGFR TKI, is called the NEO study. This was published quite recently in lung cancer, 40 patients who received 6 weeks of osimertinib. And we see here that these patients had an objective response. They did have some shrinkage of their tumor, but did not yet result in overall improved outcomes. A similar study was done at UCSF by Colin Blakely and colleagues, and again, same sorts of results. 0% of patients having complete disappearance of the tumor, some increase in pathologic response. But really, I think the opportunities here are for us to understand the biology of the cancer much better. Giving upfront targeted therapy means we can take those tumors and compare them to the biopsy beforehand and see why some patients are responding well and maybe others not so well, and identify mechanisms of resistance. So we see here certain pathways are lighting up for us, such as the YAP pathway and others, which may allow us to come up with strategies to try to mitigate resistance to EGFR TKI. NeoAdora is now a phase 3 study trying to evaluate whether giving a targeted therapy, this time with chemotherapy compared to targeted therapy alone, may be something that we do in this space. This is currently an open and accruing study. It aims to give treatment for a slightly longer duration compared to the phase 2 trials, and hoping that this longer duration may lead to better outcomes in terms of pathologic response. I think the duration of the postoperative treatment is currently under debate, and certainly there are some parallels here trying to bring the immunotherapy paradigm to targeted therapy, and we will have to see if this makes sense for this very biologically different cancer. So moving to the last area of earlier stage lung cancer, so patients with stage 3 lung cancer that unfortunately is not surgically resectable. So in the last 5 years, we saw another practice-changing study called the Pacific trial. In this trial, patients with stage 3 lung cancer that could not be operated on was treated with chemotherapy and radiation together, and patients were randomized to receiving 1 year of immunotherapy with a medicine called durvalumab compared with observation. And the study had co-primary endpoints of both overall survival and progression-free survival. And similar to the previous story, this was very much a slam dunk. So we see here 2 concurrent or 2 sequential New England Journal publications showing both a progression-free survival and an overall survival benefit of 1 year of immunotherapy after definitive chemoradiation, with impressive hazard ratios for both of these outcomes. Again, some differences between regulatory approvals. So here we saw that the European licensing restricted this treatment to those whose tumors had a PD-L1 score of greater than or equal to 1%, whereas all comers were approved for this treatment in the US. And certainly this is a hotly debated topic. Does the Pacific treatment work in the real world? Will it work for all patients necessarily, or is it only really a very fit, well clinical trial population? So this is a study again led by Dr. Peters and others, which was an expanded access program. So patients who had stage 3 lung cancer, but maybe weren't necessarily fit enough for a trial, more real world, were assessed for progression-free survival and overall survival benefit. And effectively what they showed was very similar outcomes when we give Pacific to a real-world population. However, the proportion of patients enrolled to this study maybe weren't as real-world as we would have liked them to be. Only 10% of them were over the age of 75, and only 2% of them were functionally impaired or had a poor performance status. So even though this was designed to look at a more real-world population, it still probably ended up being somewhere in between. Some important advances, recent advances in the field for this group of patients is the question of whether will it be better to give immunotherapy even concurrently with the chemotherapy and radiation. So this was a very interesting result. This was presented at the European Lung Cancer Congress in April this year. And maybe some surprising results that in this setting, moving immunotherapy earlier to happen at the same time as radiation was not helpful. So we did not see a benefit in either progression-free or overall survival if we moved the immunotherapy to start concurrently with radiation and then through afterwards. And in fact, we may even see a worsened outcome. So we saw that the patients who got immunotherapy concurrently with chemotherapy and radiation appeared to have higher rates of toxicity. And these toxicities happened within the first 4 months of treatment and generally appeared to be related to disorders of the chest, respiratory infections, bleeding, and others, and could be related to how immunotherapy is working in the body or how we might partner immunotherapy with radiation optimally. So I think the take-home message from this trial is we have to learn how to intercalate radiation with immunotherapy successfully. And giving it concurrently with immunotherapy certainly isn't the right way forward for stage 3 lung cancer. So again, shifting gears to the oncogene-addicted group, those that don't traditionally respond to immunotherapy, should they receive maintenance immunotherapy after chemoradiation if they have stage 3 disease? So this is a paper that I published in the JTO a couple of years ago, assessing the subgroup of patients enrolled to the Pacific trial who had EGFR mutations. And in the subgroup analysis, there did not appear to be a benefit for immunotherapy in this group. For other mutations, that may not necessarily be the case. For patients with KRAS mutations, we see that there did appear to be a benefit for immunotherapy. This, of course, led to a larger study called LAURA, which was presented and published this year at ASCO. In this study, patients with stage 3 lung cancer treated with chemotherapy and radiation that harbored an EGFR mutation were randomly assigned to osimertinib indefinitely versus observation. And patients could enroll on the study whether they were treated with either combined or sequential chemotherapy and radiation for their local portion. A smaller study, 200 patients, but a very clinically important question. And again, striking results that were presented showing that there is an overwhelming benefit for giving targeted therapy osimertinib compared to placebo in this disease, with a very impressive hazard ratio of 0.36, which was statistically significant, and a median progression-free survival of 39.1 months compared to just 5.6 months for placebo. And again, the forest plot all sitting on the side of the osimertinib, showing that regardless of the mutation type, age, gender, all of these factors, there appeared to be a benefit for osimertinib in this setting. So taking this all into consideration, one of the parting words that I want to leave you with is, as you can see, there's been a rapid change and expansion in our treatment options in early stage disease. And not just our treatment options, but how we approach treatment and which member of the team is going to be involved when and how. So really the multidisciplinary team or the tumor board is almost the silent treatment partner that is moving the dial of all of these treatments. So active discussions between the pulmonologist who diagnosed the lung cancer, making sure biomarker testing is done, the surgeon, the radiation oncologist, the oncologist who gives the systemic therapy, the pathologist who makes sure there's adequate tissue subtyping and molecular testing, and the radiologist who's going to tell us what the stage of this disease is in order to take us down a certain road. We have to be very integrated with all of these elements and all of these data points to make the right decision together with our patient who's sitting in the middle of this very complicated journey. And this really is an example of the discussion points that happen in our multidisciplinary tumor boards for early stage lung cancer, and it is bewildering. We see here right at the beginning, a patient gets diagnosed. First thing is, did they have biomarker testing? Because that's going to take us down very different roads. Do we have enough tissue for biomarker testing? Do we need another biopsy? Different people involved in that, the radiologist, the pulmonologist, the pathologist. Then we have our multidisciplinary team meeting where the surgeon is king. We're asking the surgeon, is this surgically resectable? Is it not? What do my biomarkers tell us? So that's the first discussion. And then we separate into those who are going to go for surgery and those who aren't. Then a key discussion with the patient, an assessment of functional status. How fit is this patient? Do they want to have surgery? Do they prefer to have upfront treatment or surgical treatment first? Most of the time, this discussion is brokered by the medical oncologist with the patient. And then one option of giving upfront treatment, neoadjuvant treatment, that would be the medical oncologist's wheelhouse. And then after that, a rediscussion sending us potentially again down a surgical route. But if we turn out not to be a surgical candidate because something has happened during treatment, we might now go down an unresectable route. If the patient has surgery, we then get a whole nother set of information related to their biomarkers and the outcomes of surgery, and then another decision and discussion point regarding should we do treatment after surgery. So we see here lots of different discussion points, lots of different people involved in those discussions, and lots of different pathways that a patient could go through that different members of the team will need to be a part of. So with that, I'd like to thank all of my colleagues and collaborators, many who work on aspects of this paradigm, all of my funding sources, and of course, really looking forward to the discussion with Amy and all of you.
Thank you, Dr. Naidu. That was an incredible overview of the amazing progress we're seeing in early stage lung cancer, and you're one of my favorite nerds. So thank you for explaining a complicated subject with such finesse and ease. You really made it something that is exceedingly complicated for those of us who think about this every day. You made it really accessible, I think, for our audience. But there is a lot of confusion. And so one of the first questions that has come through, goes back to some of the conversation I had with Dr. Peters and this, question of cure versus chronic disease. We keep saying that the sooner we can detect lung cancer, the earlier we can intervene, that opens up the opportunity for potential cure. So I just want to get your sense, based on where we are now with the data and the studies that we have, how much of early stage lung cancer is considered curable or has the potential to be managed as a chronic long-term disease?
Yeah, I think this is tricky. I mean, I think this is almost a philosophical question. What does cure mean? And listening to patients, I think cure means different things for different people. So I think broadly, cure usually means absence of disease. That there is nothing that we are managing currently, and that we feel comfortable enough that the risk of the cancer coming back for that patient is similar to the risk of the general population. And I think, that is classically, stage 1 and 2 lung cancer was always treated with curative intent. So I think we are still treating with curative intent, stage 1 and 2, some portion of stage 3s. And now it's just a greater proportion of patients that are getting to that endpoint, that we can confidently say, unlike with chemotherapy, that more patients are going to get to a point where we're getting to 2, 3, 4, even 5 years, and there appears to be no evidence of disease on a scan. But I think the philosophical part of it is there's no evidence of disease on a scan, and then there's no evidence of disease, and I have no clinical concern that it's ever going to come back. And that's a high bar. And do I ever feel completely confident to discharge a patient? It probably takes a lot. And I think some of these newer testing for the presence of tumor DNA in the blood, if there's some circulating tumor cells, I think these types of tests are going to help us to truly understand what cure means. But hopefully, there will be more patients in which we start to feel confident to say that.
Right. And I'm glad you brought that point about circulating tumor DNA, because that was actually my next question for you, is what is the role of what we call liquid biopsy, sampling blood, looking for the presence of that DNA that is shed from the tumor in early stage disease? Because we often, we talk about, the bigger the tumor, the more likely it is to shed. And so how great is the sensitivity and our ability to detect that ctDNA in early stage disease? And I want to just hear a little bit more about how you all are thinking about using that liquid biopsy technology to assess things like, duration of treatment, this, idea of chronic versus cure, monitoring for relapse. Can you expand a little bit on the role of ctDNA in the early stage setting?
Yeah, so I think there are pros and cons. So first of all, we use ctDNA or liquid biopsy now clinically for the purposes of diagnosing whether somebody has an oncogene-addicted lung cancer. So patients with advanced disease, we use that now in order to identify if somebody has a biomarker-driven lung cancer that will lead us to a targeted therapy. So that's its current use. Its uses in early stage disease for the purposes of treatment selection are all still investigational. And I think this is related to the fact that we appreciate liquid biopsy or cell-free DNA has some technical limitations to its ability to be applied in early stage lung cancer universally. So if you look at a lot of data on studies evaluating the circulating tumor DNA in this early stage disease setting, and there was a couple of papers on this at ESMO. Most tumors now are classified into shedders and non-shedders. So tumors that tend to shed their DNA into the bloodstream and those that don't. And volume of disease appears to factor into this. If somebody has more disease, they're more likely to have detectable DNA in the blood, whereas those that are smaller do not. So it does appear that ctDNA is in some ways prognostic. It's likely to tell us who is likely to do well or not. That is a very different question to, can it inform a change in a person's treatment? So that is, we are not there yet. I think we are confident to say that it is a prognostic element, but because it may not be detectable in every patient, its ability to reliably inform us who needs more or less treatment really requires more study. So there are a couple of studies now doing de-escalation approaches, where if you don't have detectable DNA, could you do less? There are more studies using escalating approaches. If you have circulating tumor DNA, I add more. Overall, I think the field feels a little bit more confident about an escalation approach because you are doing more for the patient. Where we become uncomfortable is a de-escalation approach, because you never want to undertreat somebody based on a test that may or may not be relevant or may be difficult to interpret in their particular case. So I think we're excited about circulating tumor DNA. There are some technical limitations. There are different types of assay that give us different information. And we need to work on all of those things before we will reliably be able to tell a patient that their treatment is changing as a result of it.
Right. Very helpful. Thank you for that. Another topic that comes up, or question that comes up in the community in the early stage setting, is thinking about duration of treatment. How long do I need to continue on immunotherapy or targeted therapy? And, it can be somewhat daunting to hear that this may be an indefinite treatment for patients. So what is the current thinking in the field for immunotherapy, targeted therapy, for duration? How long is acceptable? And for, patients that induces anxiety when you think about discontinuing a treatment after a certain period of time, that fear of the cancer coming back. So can you tell us a little bit about the thoughts of the field in that regard?
Yeah, so I think, in advanced disease, we feel a little bit more comfortable in that treatment is given indefinitely at stage 4 disease. And, the tailoring of how many doses of treatment is really based on side effect profile. I think when we think about targeted therapy, in all of the targeted therapy studies, nobody achieved long-term cure who came off targeted therapy. So we would see a rapid drop-off of the curve in those patients who stopped, whereas that is the difference with immunotherapy, is that you see a tail on the curve phenomenon in that patients are living. But I think what we appreciate is that the optimum number of doses of immunotherapy is unknown. There's been a couple of studies trying to identify this. There was a French cooperative group study that was presented a year or two ago at ESMO, looking at 6 months of immunotherapy and whether this was potentially something we could do with combination. And it actually stopped. It was actually not able to accrue fully because patients weren't really comfortable stopping. So I think doing some of these duration studies are difficult because of these elements that you describe and because of approvals that have now happened. But I think this links to duration is one question, but de-escalation is another. So that's a similar question. It's not necessarily duration, but maybe it's dose. Maybe the doses don't need to happen as often as they are prescribed. Maybe the absolute dose to rev up your immune system is not necessarily the dose that is licensed. So we've seen some really interesting data. First publication, I think, was in head and neck cancer from a group in India, showing non-inferiority of giving a low dose of immunotherapy in head and neck cancer patients. And now there are increasing studies of de-escalation approaches. I think it's very important for us to do these studies because it will give us more information about toxicity. It will give us more information about long-term outcomes. But right now, it's a terrible answer, but I think we do not know the optimum duration, and we do need to do that work.
I wish we had more time because I have so many questions, but we have time maybe for one more, and that is, you talked about the difference between immunotherapy, targeted therapy, and the early stage setting. And so, obviously we're doing biomarker testing primarily for advanced stage disease, with the data we're seeing for EGFR and ALK. Now we know that there's really a need to test all people at the point of diagnosis and move that earlier as well. So where are we, in that regard of making sure that all patients, regardless of stage, get access to biomarker testing?
Where are we with it? Is that the question? Yeah.
Yes.
So we've seen the data for stage 4 disease that we've known for many years that biomarker testing is a standard of care in lung cancer, PD-L1 testing and an expanding list of mutation testing. But regardless of that, the uptake of complete biomarker testing in real world settings is around 50 to 60%, and not everybody is getting it. And it cranks up a notch more complicated when we talk about early stage disease where we don't have a lot of tissue, and when we need an answer relatively quickly in order to pick the different pathways. If we know somebody has an EGFR mutation, they must not get neoadjuvant. So now all of a sudden we need this result in a short period of time in order to make a surgical decision. This is a very sort of disruptive way of thinking. I need a biomarker test to tell me about surgery. Like, that requires a different type of thinking. And certainly I think all of us who are in a healthcare scenario, we need to be a little bit more holistic about who we talk about these kinds of data to. I think surgeons now need to be well-versed in biomarker literature. Medical oncologists need to be well-versed in surgery. These are, learning to speak different languages. So I think, where are we in biomarker testing strategies for early stage? We're at the very beginning of a very complicated journey. And I think what will happen is that there will be lots of different pathways that are used. There are some who will do hotspot testing to rule out EGFR and ALK so that they can go down the neoadjuvant pathway and then do full biomarker testing on the surgical sample. There will be those that try to do the full biomarker testing up front. There will be those that say, oh, I can't do this, so maybe I'll give everybody neoadjuvant chemo IO and see how that goes. But that is going to be very tricky to do in real time. And then again, incorporating liquid biopsy in that, what's the best way to do that? And knowing that the sensitivity of liquid biopsy is not as good as tissue, what's our comfort level of doing liquid biopsy in that early stage setting? So I think we're at the very beginning of these discussions, and all of us are having these discussions with our pathologists and our surgeons and our pulmonologists who do the initial testing now to try to iron out these approaches. And I think it's only going to get more complicated. We know about EGFR and ALK, but now we have KRAS inhibitors coming on stream. We have other types of targeted therapy. I think we have to also develop a system that is in some ways adaptable, because we're going to have to add on more markers in the next couple of years. So the system is going to have some give in it to allow for change.
I appreciate that. Very thoughtful response. Well, again, it's been lovely to have you with us. Thank you for making time in your schedule, fresh on the heels of 2 back-to-back conferences. But it's always a pleasure to be with you, and thank you again.
Thanks so much, Amy. A pleasure and a privilege to be here and to talk to the people that matter most. Thank you.
Thank you.